Okay. Hore mai and good evening. Welcome to the second webinar series for Sarcoma Foundation New Zealand. Tonight's chair is Andy Johnston, one of our board members, and we're delighted to have our guest speaker, Clement Korenbaum, on the topic of desmoid tumours. So over to Andy and Clement.
Thanks, Joanna. So yeah, welcome everyone, and thanks very much for teaming in. We are going to talk tonight about desmoid type fibromatosis or aggressive fibromatosis. There are a few different names for the same entity. And we're very lucky to have Clement Korenbaum, who is one of the medical oncologists in the North Island Sarcoma Service and a bit of an expert on desmoid fibromatosis to give us an update on management of this condition. Similarly to the last webinar, if you pop your questions in the Q&A rather than the chat, then I'll ask them either at the right point or at the end when we have a question and answer session. And without any further ado, I'll hand over to Clement.
Thank you, Andy, and kia ora, everyone, and thank you for attending this session, and thanks for inviting me, the Sarcoma Foundation New Zealand. I think it's a great initiative. And yeah, tonight's topic is desmoid fibromatosis, a rare disease, but it's worth knowing about it. So we're going to go through what it is, how we look after patients with desmoid fibromatosis. I'll just start sharing my screen. Can everyone see the presentation well?
Yes.
That's good.
All right. Oh, thank you. So, yeah, desmoid fibromatosis is a bit of an odd name, and what it is, it's actually a very rare disease, rare illness. It's what we call a locally aggressive soft tissue tumor, a mass of tissue that is made of an uncontrolled proliferation of cells called the fibroblasts. And those cells are usually the cells that make up for the connection between our organs, the connective tissues. And so those disease makes up for a lump of tissue. It can grow and then cause a problem such as compression or infiltration of nearby organs. They have several names. They're also known as desmoid tumor or desmoid type fibromatosis, but it all refers to the same entity. Challenging to manage for doctors because they are very rare, variable cause, variable presentation. People might not know what it is. And also because it's rare, there's a lack of approved therapy. When we say rare, we are talking about 5 cases per 1 million of population per year, and that's the same worldwide. It affects females more than male, with a peak at a young adulthood around 30 years of age. They're usually sporadic. It means that they come out of the blue, not inherited, but in some very specific case, they can arise in the context of a condition called familial adenomatous polyposis, which is inherited and also predisposes to colon cancer. They are driven by a change in the DNA, changes in genes. 2 genes are usually causing the desmoid, the beta-catenin gene and the APC gene. And we usually find typical mutation, typical changes in the genes when we look at the DNAs of those tumors. So why are they a problem? Of course, they can cause pain because it's like having a foreign body growing inside of you and can lead to functional deficits and debility with disfiguration, psychological problems, and decreased quality of life. It is really a chronic disease, very hard to get rid of it entirely. So what does it look like? As you can imagine, it's like a soft tissue ball under the skin that can grow to significantly large pictures. You can see on those images on the left-hand side that this person has a right mid-back sizable tumor, and surely that results in major discomfort. To better characterize, to understand the relationship between the tumor and the nearby organs, we use imaging techniques such as MRI, as you see on the right side, with the arrows showing you a desmoid fibromatosis of the right lower neck, and you can understand that it's very close to the lungs, very close to some bones, some important nerves and vessels, so it's going to be very tricky to manage if it starts growing in a narrow space. Where do we find desmoid fibromatosis? Most of the time, they would arise from the extremities, the lower extremities particularly, but also the abdominal wall and the scapular girdle, so around the shoulders. But they can also affect any part of the body. And some of them can be intra-abdominal and cause problem with our gut. How do they typically present? It usually starts as a painless or minimally painful mass. Usually there's a history of a slow growth. It doesn't grow very rapidly. And it's a single lesion. There are not many lumps at once, although occasionally there can be what we call multifocal, being in several areas at once. They do not spread. It's very important to understand that those are tumor, but not cancers, and they do not spread to distant organs, so are very unlikely to affect people's life expectancy. But of course, they can result, as we said, in a number of debilitating symptoms. On the right-hand side of the figure, you see imaging, again, MRI, showing the calf affected by a desmoid fibromatosis, and a CT scan, a cross-sectional imaging. It's like looking at a tree that has been cut, and we're looking at the rings, and showing a large tumor inside the abdomen that's going to cause problem to the nearby structure, including the gut. How do we get to a diagnosis of desmoid fibromatosis? We need tissue, so we need a biopsy. A biopsy is a sample of tissue, and there's a specific way to do this, and it's usually done by experienced and specific radiologist or surgeon using particular needles called the trocut that takes a little sample from the tumor without breaching into the surrounding skin. And it is not a procedure that every doctor can do. It has to be done in a specific center, preferably, and sometimes they need some imaging technique to do this properly, such as a CT scan or an ultrasound. Then the sample is sent to the lab, and the pathologist will cut it through and look at it under a microscope. Everybody has had dinner, so I can show a picture of what it looks like for if someone has had surgery, for example. And you can see this, see here a desmoid tumor that has been removed from close to someone's spine, and you can see what it looks like, very sort of whitish substance that looks like a scar tissue. And under the microscope, all the cells look the same because it's a one clone of a cell that proliferates indefinitely. And pathologists use colors, brown colors called stains, to further characterize and to refine the diagnosis. Very important to say that not every pathologist would come across this often, so pathologists work together and refer typical cases to each other to make sure they get to the right diagnosis, because then the treatment is vastly different between the desmoid fibromatosis and another tumor. So, because they are not cancer, the survival of people with desmoid fibromatosis is usually unaffected. If you look at those curves on the left, what are they? They show you with on the y-axis the probability, that's a percentage, and that OS curve, the blue curve at the top, is the probability of being alive. So it's actually the mortality, and the 1 at the top means 100%, and the x-axis shows you the time in months. So you can see that typically from diagnosis to more than 5 years after the diagnosis, it's extremely rare to see somebody dying from a desmoid fibromatosis, fortunately, again, because those tumors do not travel to other parts of the body. However, when you look at the same people with another indicator called the DFS, the disease-free survival, it's the period without disease recurring, you see that a lot of people would see that their tumor grows at some point, and this can affect the quality of life because you will need treatment. You see on the right side a person that has had surgery for a desmoid tumor that can affect the mobility of the left shoulder and also the cosmesis. So what is the current treatment landscape of those desmoid fibromatosis? So active surveillance, it means watching the tumor and doing nothing. We'll discuss this a little bit further in a minute. Surgery and local therapies. Radiation therapy, radiotherapy is not as used as previously, but still it can be useful. And what we call systemic and medical treatment, which are usually now the first treatment that we use. And we will discuss each of them further in the next few minutes. Of course, what's important when treating rare disease is to work with collegiality. And there's a global initiative since 2014, which is the Global Desmoid Consensus Meeting, that initiated a gathering of many experts from all around the world to reflect on what is the best treatment for patients with desmoid fibromatosis. So it's actually and it includes surgeons, medical oncologists, pathologists, radiation oncologists, physicians, but also patient advocates. So it's very reassuring to see there's a global network of expertise of people working together, and occasionally once every 5 years gathering and coming up with a paper, which is a guideline for everyone to use and follow, depending on each country's expertise and availability when it comes to pharmaceuticals. Essential role of multidisciplinary meeting: we cannot make treatment decision just on our own for such rare tumors. So we need to bring together surgeons, medical oncologists, radiation oncologists, pathologists, nurses, specialists, and it's highly recommended, it should be even mandatory, to discuss all those cases because they are so complex to manage. No one can claim that it has the one expertise in the field. So active surveillance, what is that? It's actually now the primary or the frontline approach over any intervention for dealing with desmoid fibromatosis. It's an effective strategy because it allows to select the patient for treatment, and it will spare patients from unnecessary aggressive treatment. So what is this? It's actually looking at the patient and doing imaging studies such as MRIs every 3 to 6 months. And it allows to understand the behavior of the disease and prevent from over-treatment. And why is that so important? Is that because on active surveillance, actually, most of the time, the desmoid fibromatosis will stabilize by itself or even reduce by itself without any intervention. So it's quite a unique feature. It really doesn't behave like a cancer. It's a tumor that can grow initially, then stop growing, and then reduce on its own without any medicine or surgery. Having said that, that time to stabilization can be a bit long. Some study suggests that it could be up to 30 months, so you have to be very patient. And of course, we can only have the luxury of patience if the desmoid fibromatosis is not growing in a particularly difficult area, such as close to an important organ. That stabilization takes longer in younger patients, so it's all about managing time and making sure that we don't miss the window of opportunity for treatment. Active surveillance may fail, and there are risk factors for failure, such as large tumors or painful tumors at presentation, the type of gene mutation that we find in the tumor, and some location. For the 20% of patients who will see their disease getting worse and needing treatment, the time until they actually need treatment can vary from 6 to 20 months. So there's no rush in any treatment decision. It's very important to bring collegiality and multidisciplinarity and not rush any decision. And if after active surveillance, the tumor keeps growing, then usually we use medical therapy. Historically, doctors and nurses used to use anti-hormone therapy such as tamoxifen, anti-inflammatory medicines such as Solindac and celecoxib, but there's actually very low and poor evidence to support the use of those, especially when we know that just active surveillance can result in a shrinkage of the tumor. Chemotherapy is still used quite a bit and uses a drug that destroys tumor cells. It can stop the growth of cancer and non-cancer cells. Usually they are much lower dose than the cancer treatments, but they have side effects and they might take a lot of time to work. Usually we say it's very difficult to assess the efficacy of a medical therapy before 6 to 12 months. Example of drugs that we use are the vinblastine, the methotrexate, the vinorelbine, and sometimes the pegylated liposomal doxorubicin. Some are tablets, oral, some are intravenous. So there are a range and diversity of treatment that we can discuss depending on patient's preference and particular context. There's also another realm of systemic medical therapy, which are the so-called targeted therapy. They work differently than chemotherapy. They're usually oral, taken by mouth, and they block the growth signals that are inside the tumor cells. They have very specific side effects, so the tolerability can be challenging. Example of those you might have heard of, the sorafenib, the imatinib, or the pazopanib. And newer agents are now being marketed, such as the nirogacestat. They all have quite a high price tag, and not all of them are funded in New Zealand. With any of those therapies, it's always important to remember that we need a long duration of treatment before assessing their efficacy, and that's the best sequence, which one to use first, is actually unknown. But if we want to be back to the basis and keep with the two therapies that have the best evidence from the studies, those are the sorafenib and the nirogacestat, because they are the only one having been assessed by what we call phase 3 clinical trials, which is one of the highest level of evidence we can find in medicine. Now, if medical therapy is not working or not appropriate, then we can discuss with the interventional radiologist about what we call local ablative therapies. It's not surgery. It's like trying to destroy the tumor without cutting people open. And one of the major techniques that is now gaining momentum and getting more and more evidence for desmoid tumor is called cryoablation. It actually freezes the tumor with some extreme cold. How does that work? There's a specific needle called a cryoprobe through which is injected a very cold gas into the tumor, and the tumor freezes and eventually dies. It works very well on small tumor, and it is known to improve functional status such as mobility, function, and also pain. Very good for pain. But it can be very challenging to use when the tumors are very large, because there's a risk of not covering all the tumor and that the tumor can regrow after that. Also, it can damage the surrounding tissue, so it really requires a particular expertise. Luckily enough, in Auckland, we have a team able to perform this. On the right-hand side, you see a cryoablation procedure. Under a CT scan, you see the cryoprobes being inserted into the patient, and the procedure goes by cycles of freezing and thawing. So there's good evidence for this after failure of medical therapy. There was one trial called Desmoid, and there's actually an ongoing trial which tries to use cryoablation earlier in the course of the disease, just after failure of active surveillance, not after failure of medical therapy. There are other local ablative therapies that are being developed, but they are still in their early days. One of them is the high-intensity focused ultrasonography, HIFU, which is basically using like a high-energy ultrasound with the same principle of a magnifying glass that you would use under the sun to concentrate the beams from the sunlight. And it's non-invasive, and it seems to be promising and to work well in small tumors. Another original way to tackle tumors that are not amenable to other therapies called transarterial chemoembolization. It is a technique that is already used widely to treat other kind of tumors or cancers, such as some liver cancers, and it consists in clogging the blood vessels that are nourishing the tumor with microbeads, microspheres that are loaded with chemotherapy. So sort of a targeted administration of chemotherapy and trying to choke the tumor. So it can be useful when the location of the desmoid tumor is particularly challenging and cryoablation is not appropriate. That's all for the local ablative therapies. How about surgery? Surgery used to be the first treatment for desmoid tumor. It was the historical treatment for decades, if not centuries. The problem with surgery and desmoid tumor is that there is a very high risk of relapse, which is up to between 30 and 75%, depending on where it is. And when discussing surgery for desmoid fibromatosis, you always have to think of what if you do a big surgery, and what happens if the tumor relapses despite of this? Because this is usually when the problem happens. It can be sometimes very extensive surgery, removing a lot of tissue around it. And then what if the tumor regrows and there's no possibility for another operation, but the patient still have the after effect of the surgery? That's a very, very important question. Planning if surgery is to be performed. There are some remaining indications that are quite indisputable. For example, if there's a deep-seated inside the abdomen tumor that is causing complications, for example, perforating a hole in the gut or causing lack of blood supply to the gut, then it needs, or causing infection, it needs urgent treatment with surgery. Or when a desmoid fibromatosis has progressed on medical treatment and is not amenable to locally ablative therapy. Also, some sites can be safely treated with surgery, such as the abdominal wall. We know that with abdominal wall, a surgery is usually a good way to safely remove those desmoids just at that site. To give you an example of the risk of recurrence after surgery, it seems to depend on where is the desmoid fibromatosis located. And a study on more than 700 patients in 2017 looked at what happened to the patients having surgery or observation or surveillance in different locations. And the researchers were able to identify some favorable locations where the surgery was not actually too detrimental, but still observation would do the same. This is the top curve, but still with quite a high risk of recurrence of 30%. And also unfavorable location like the head and neck, the chest wall, or the upper limb, where a vast majority of patients would recur after the surgery, and those patients would usually be better off just having observation, and that's the curve on the bottom part. When surgery is not appropriate and medical treatment has failed, then there's also the possibility of calling the radiation oncologist for expertise and using external beam radiation therapy. What is this? It is basically using targeted high energy radiation beam. How do you generate this? You can see the machine on the right-hand side of the panel, and at the bottom you can see that electrons are generated by an electron cannon, and they are accelerated in a tube, they hit a target, which is usually tungsten, and they are changed into photons, and those photons will then hit the target inside somebody's body and deliver an energy that's going to break the DNA and cause a reduction of the volume of the tumor. Radiotherapy is a very efficient treatment for many different cancers, but it can have side effects. So if you're treating a tumor that is unlikely to put somebody's life at risk, you need to be very careful that the side effects, especially the long-term side effects in young people, are not too bad. And one concern with radiation therapy is the risk of second cancer, the risk of having a cancer from the radiation therapy years, if not decades after the treatment. So we need to be very careful when discussing radiation therapy, but still, sometimes we have no other choice, and it is an efficient treatment for desmoid when it is well used. Previously, it has been proposed that radiation could be used as an adjunctive surgery. Say a surgery was performed, was not complete, and then surgery was, and then radiotherapy would be given after the surgery. This is what we call adjuvant radiotherapy. But now we believe that by doing that strategy, even though we reduce the risk of local relapse of the desmoid tumor, there is still a high risk of over-treating a lot of patients when those patients could be just on active surveillance, observation, and do very well. And of course, on top of any of those treatments are the supportive care, because having a desmoid fibromatosis can be super overwhelming and can impact all aspects of life, social aspect, economic aspect, and all of our relationships to others. Because being in pain, having a tumor can be a constant worry and can be quite overwhelming. And on top of that, it is a rare disease, so it's very hard to find people who are like you with the same problem and who are really able to understand what you're going through. So this is why it's so important that we refer our patient for counseling, nursing, psychological support, physiotherapy, and this is what we call the interdisciplinary supportive care. Also managing pain medicines when they are necessary. Some patients need to be on long-term pain medicine and they all have side effects. So it's very important to be in constant communication with the community, the GP, the allied health. And also for the patient, there are more and more support groups internationally. And I just downloaded that little map at the bottom right, showing all the groups that are available. And I'm sure there will be a link to this on the Sarcoma Foundation website later on. So in summary, how do we manage desmoid fibromatosis currently? First, we need a diagnosis, and we need an expert people to do the diagnosis to make sure that take the right sample in the right area and it's reviewed by the right person who knows what to look for. And the patient then needs to be referred to a center where there's expertise and multidisciplinary input. And then, of course, if the tumor is threatening to life because it's close to a very important organ, or there's a lot of pain, or it impacts with the quality of life significantly, then we consider treatment, which could be usually start with a medical treatment. But if it's not the case, the frontline approach for a majority of patients will be active surveillance. And a lot of patients will do well on active surveillance and will not require ever a treatment because their disease will stabilize and eventually reduce by itself. And if it changes over time, they need to always reconsider treatment. So follow-up is very important, and usually patients know when and where to find us and to call us when there's a need for treatment. In conclusion, I'm sure you have now understood that this is a rare chronic disease, that the multidisciplinary is the key of the care, and we need to be collaborative between each other with an approach that's centered on what the patient wants. Collaborative research is very important, and I've illustrated this with that international collaboration because it is a rare disease. Active surveillance, that's the mainstay of the initial care for those desmoid fibromatosis. And then we can discuss the medical treatments, many historical treatments with low evidence, but some new ones with better evidence. None of them are available in New Zealand. Accessibility and cost have to be taken into account within each particular country. Local ablative therapy is on the rise for desmoid tumors, so watch that space, and surgery can still be used in selected cases. And there's a variety of treatment, but you always have to adjust with the expertise you have. Of course, if you're in a center that has an excellent surgical team and no access to interventional radiology, then you might work more with your surgeon. And if you have more drug funded in a country and not in another, you might use different combination of chemotherapy or new drug. You have to adjust with what's available. And with this, I would like to thank you all. Thank you for the Sarcoma Foundation for the invitation. Thank you, Andy and Joanna. And I'm really happy to take questions.
Thank you, Clement. That was fantastic, very informative. A couple of questions have come through in the Q&A, and I'll phrase those to you. And I think I've got a couple of other ones that have been passed on to before the meeting. So someone has asked, getting a cancer diagnosis is devastating for a patient from a patient perspective. The watch and wait approach can be very scary, and there's a high level of trust required. How do you manage that? And I guess, of course, I'd first say that particularly desmoid is not cancer, and so you know, that with that caveat, how do you manage that watch and wait?
I think, yeah, first of all, that's absolutely true, that comment. You know, of course, so it can be very hard psychologically to be on that watch and wait approach, knowing that you have a tumor. Of course, it's not a cancer. We know it's not going to spread. It's not going to be a threat to the life unless it is close from an important organ. But it is true that hopefully we have accumulating and more evidence globally and internationally that it's actually the right thing to do, to watch, because when you look at the number, it's up to 2/3 of those tumors that would spontaneously stop growing and then start shrinking by themselves. But yes, you need to be patient. And yes, you don't want to miss that window of opportunity when the tumor is actually about to cause problem. And yes, you need to start treatment. So it's an ongoing discussion you need to have with the patients to best understand the best interval between the scans, for example. Usually it's every 3 to 6 months. There's usually no reason to do this more frequently than that because those tumors are not growing so fast. But yes, managing that risk is very important. Also, potentially using some of the risk factors to try to predict the behavior of the tumor. We know if it's a very big tumor to start with, it is less likely to behave well on active surveillance. We know if it's a particularly young patient, it's likely to take longer to stabilize. If we can identify that particular mutation, S45, if we can predict that it's less likely to respond to active surveillance as well. So we have factors to try and fine-tune our advice, but it's called active surveillance for a reason. It needs to be active with very regular monitoring. Yeah.
Okay, thank you very much, Clement. Is cryotherapy and other external beam radiation therapy used in other forms of sarcoma treatment?
So desmoid fibromatosis is it is usually cared within the realm of soft tissue sarcoma, but it's actually a very specific entity within the soft tissue sarcoma. Soft tissue sarcomas are a different disease because they are cancer and they have the potential to metastasize. And some of the strategy for those cancer who have the potential to metastasize is, of course, when they are in one area, is to try and remove them. And when they unfortunately start to spread, then you have to try and understand how you can best mitigate the growth of the further spread of the tumor. And it's a very personalized treatment. It's at each step of the disease, and unfortunately when it spread, it's almost impossible to cure. Each time you consider the disease, you have to open your toolbox and try to use the right tool at the right time. And sometimes that tool will be, yes, a cryoablation or surgery or radiation for this particular cancer spot, or maybe it might be some chemotherapy, or it might be that you don't need you actually need nothing because the cancer is growing slowly. So it's really personalized. But cryoablation, radiation therapy are techniques that are being used for other kind of cancer. Cryoablation was actually used primarily for kidney cancers.
Yeah, thank you very much. Just on that kind of same note about who gets what and who decides, if patients refer to the multidisciplinary meeting, who decides who operates or who gets an operation and where the surgery will be performed?
That's a good question. So usually in a country like New Zealand, which is relatively small, a patient would be referred where the expertise is. People work collaboratively. People tend to know their limits very well. If they belong to a team that looks after a lot of soft tissue sarcoma and desmoid tumor and have the expertise to do this, then of course they will look after the patients. But usually because those tumors are so rare, we try to centralize the care. So for the North Island, it would be in Auckland usually, and for the South Island, it would be around Christchurch, where you have surgeons who have expertise and training for those diseases.
Perfect. Thank you very much. You mentioned some newer therapies such as nirogacestat. Is that available in all of New Zealand for people with desmoid, or?
So it has just been licensed by the FDA in the US, so it's very, very new. For now, it is not available in New Zealand. It is not funded in New Zealand. If people want to buy it, we had to check the other day. It's really expensive. It's more than several tens of thousands of dollars per month. At the moment, at Auckland Hospital, there is what we call an access program, which means that we can, under specific condition, apply to the pharmaceutical industry, and that would sometime deliver to some of our patients for free. And I don't think there is a limit into how many centers or hospitals can apply for this program. So even if people are treated in another hospital, they can discuss with their local doctors, and the local doctors can be in contact with the pharmaceutical partner and then open a program. But there is one currently open in Auckland. I'm not too sure about any other cities in New Zealand at the moment.
Thank you. I have some really good questions coming through. Someone's asked, what level of pain and disease progression do you decide to take the patient off active surveillance and put them onto some form of treatment pathway, whichever one's appropriate for that particular tumor location and patient?
Yeah, I'd say usually we don't decide, the patient will tell us, and it really depends on the discomfort and the pain threshold that the patient might experience. And it's when we review patients every 3 months, for example, of course, sometimes we have some concerns because we see that the MRI is looking a bit worse, but the patient actually tells us that he has no problem and there's no pain and there's no discomfort. So we might, in that case, just continue with active surveillance. On the opposite, sometimes the tumor doesn't grow a lot, but starts to cause a lot of discomfort and pain, and this is our signal. So I think it's more dictated by what the patient is telling and experiencing rather than us judging just on images. Always try to remember we're not treating scans, we're treating people. Yeah.
Perfect, thank you. If you are a patient, and this is just a generic question, if you're a patient who's went to your GP and you found a new lump on your arm or your chest wall, abdominal wall, what would you expect to happen? What should you expect to happen from your family doctor, and what should happen after you've seen them?
Yeah, I think now family doctors are more and more educated that any lump that's more than 3-5 centimeters, more than a golf ball basically, and that doesn't have a very clear explanation, needs to be investigated properly, first with some imaging and by a surgeon or a radiologist to make sure that this could not be a rare disease such as a desmoid tumor or such as a sarcoma, because the initial management of those tumors is crucial for the long-term outcome, and you really the last thing you want is somebody going a bit rogue and trying to remove a big lump when there's no clear explanation for this lump. Having said that, we are always a bit paranoid because we work in oncology, but it is true that the vast majority of lumps have a clear explanation of very slow growing, would be lipoma, but there are factors for the GPs to identify. If there's not a clear explanation to a lump, it should be referred to an orthopedic surgeon primarily. Yeah.
Okay, thank you very much. Just to clear up, because it is quite a complex pathway. Just to reiterate again, why do some patients get, for example, cryotherapy? Why do some get, when we go for active management, why do some patients get cryo? Why do some patients get drugs like nirogacestat? Why do some patients get surgery up front? Could you just clarify that for people?
Yeah, absolutely. So it will depend on where is the tumor located, on a number of parameters. Where is the tumor located? If it's not close to any important organ but is growing and starting to cause pain, then you might just consider medical treatment, because you know that your medical treatment is going to take a while to start working, 6 to 12 months. As a reminder, if you see that the disease is rapidly progressing and you are concerned that it's going to cause some damage to surrounding organs, then you will need a treatment that has more of an immediate result. And this is where potentially cryoablation is interesting, and surgery and radiation can be discussed as well. It all depends on the location and how fast it is causing symptoms or growing.
Yeah, perfect. Thank you very much. Well, I think we've gone through most people's questions. That's fantastic, and thank you very much for those who were asking questions. Very grateful for your time, Clement, and giving such a fantastic presentation. The presentation will be available on the website through the Sarcoma Foundation YouTube channel within the next few days. So if someone who missed this, then please feel free to send them to the website, where they can not only see the YouTube link to this talk, but also there is a very good desmoid type fibromatosis information leaflet on there for information and support for patients. And hopefully for those who have joined us over Teams, it would be lovely to see you all come and meet the team and meet everyone else at the Round the Bays in Auckland early next year, if you can at all make it. Thank you once again, Clement, and I'll hand you back to Joanna just to sign off.
Thanks, team. So that just draws our conclusion of the second webinar. So our next webinar, the date will be decided, but the third webinar will be in the new year, most likely the first quarter, but stay tuned for more. Good night, everyone.
Good night, and thank you.